Good morning or good day. My name is Neal Shonnard. I'm the medical director for the Spine Scoap project, and we're forming a series of vignettes that describe some of the work that the Abstractors do for gathering data to input into Spine Scoap. I want to thank you for joining us in this historic and very important endeavor, and really appreciate your enthusiasm and efforts to get this important information available to our patients. We're going to roll out Spine Scoap in January of 2012, with the pilot study having been completed before that, from the months of July through December. And from our initial rollout, we hope to gather more and more hospitals, more and more doctors, and more patients, until everyone in the state of Washington has the opportunity to participate in Spine Scoap and measure the benefits that their procedures bring. We're going to talk about disc herniation. Disc herniation occurs in the lower back, or what's called the lumbar spine, and in the neck, what's called the cervical spine. When the disc herniates, it moves from its central position as a shock absorber pad between the bones of the spine, and in the lumbar spine there are 5 of them. Each of the discs is numbered by the position it has in between the bones. So this is an L1 and L2 bone. So this is the L1-2 disc. This would be the L2-3 disc, 3-4, 4-5. And the sacrum is called S1. So L5-S1 disc is down at the bottom. When disc herniations occur, they can occur to the left or to the right, and when they hit the nerve going to the right leg is painful. When they hit the nerve going to the left leg is painful. When we look at discs in profile, so now what we're doing is just looking at a single motion segment taken from the lumbar spine. And when we look at it from a viewed on top or from below, we see that the disc is in the center and the nerves go off to either side, and the disc does not touch the nerves. When a disc herniation occurs, the central content of the disc goes out through the rim and the retaining wall and bulges out. When it does so, it directly hits the nerve. And in this model, the disc herniation hits the nerve on the left, so this would give the patient left leg pain. So this is what the model of the disc herniation looks like. As we look at an artist's description of it on paper, so this would be from a brochure that would be given to the patient, we see that the disc herniation bulges back and hits the nerve, and the surgical procedure to relieve the painful leg, the pain that's coming from this nerve going down the left leg, is called a microdiscectomy. The microdiscectomy usually implies that it is done under a microscope using minimally invasive techniques, and as this picture demonstrates, an incision is made, an instrument is used to grab the free fragment and pull it out, very much like you would grab a splinter and take it out of your finger, or grab a stone and remove it from your shoe and then put your shoe back on. When you remove this fragment, the pressure on the nerve is relieved and the nerve pain stops. That's a lumbar microdiscectomy. Now, a disc herniation can also occur in the cervical spine, but since the cervical spine bones are so much smaller than the lumbar spine bones, the model to show disc herniation is not effectively shown when it gets this small. So we will take what we know to be the circumstance of disc herniation in the lumbar spine and simply transpose it to the cervical spine. Now, in the cervical spine, your treatment options are different. The disease is the same, but the treatment options are different. So when we look at the cervical spine, we have multiple discs where the herniation can occur, just like in the lumbar spine. They are numbered the same way as they are in the lumbar spine. This is going to be the 2-3 disc, the 3-4, the 4-5, the 5-6, the 6-7. When the disc herniation occurs, the disc material bulges back and hits the nerve going down the arm, and this causes the arm to be very painful. And that's analogous to the leg being very painful when a disc herniation occurs in the lumbar spine. The exact same disease process, the exact same pain pattern occurs, except that it occurs in the arm instead of the leg. The treatment options, however, are slightly different. In the back, the lower lumbar spine, you can do discectomy, and that's usually the only thing that needs to be done. In the cervical spine, you have the option of removing the disc from the front through an incision in the front of the neck, taking an instrument and removing all of the disc material so that you can get back to the disc fragment that's pushing on the nerve. When that entire disc is removed, you now have a hole in your neck, and you need to fill that hole with something or your neck will collapse into the hole. So routinely, doctors have two choices: to put in a bone fragment, which is often called an allograft, or a bone fragment taken from your hip, which is called an iliac crest autograft. If you use a bone, routinely you commonly put a plate on the front of the bone plug so that the bone plug doesn't spit out of position. The plate closes the front of the spine so that the bone plug stays in place until it heals. You also have the option, instead of putting in a bone plug, you can put in an artificial disc replacement. The same process occurs up to this point. The disc is completely removed. The fragment that's pushing on the nerve that's causing the pain, either in the arm, or the fragment that's pushing on the spinal cord, which is causing the spinal cord compression, is removed in both circumstances. The fragment and all the disc is removed, but instead of putting in a bone plug, an artificial disc replacement is put in. Now, this is two bone segment of the spine taken from the neck. Any two bones are the same, so we just need to look at these two bone segments. And what you have is a two-piece disc replacement. You have a lower piece which has a plastic ball on it that has a sintered surface and a keel in the bottom plate to lock it to the bottom bone. You have a sintered surface and a keel on the top plate that locks it to the top bone, and the undersurface of the top plate is perfectly radiused as a ball and socket joint to fit on the bottom plate so that the neck keeps moving. The disc fragment has been removed, but a disc replacement that allows the neck to continue to move normally has been put in instead of the bone fusion, which stops the neck from moving normally. Half of patients with a disc herniation in the neck will be a reasonable candidate for this alternative operation. Half of the patients will be a reasonable candidate for the fusion alternative operation. So in review, in the lumbar spine, removal of the disc is the usual, customary, and only treatment option. In the cervical spine, removal of the disc and disc replacement can occur, or removal of the disc and bone fusion can occur. And then there is a third option which allows for removal of the disc and no fusion. and that option is exercised by the location of the disc herniation. In this artist drawing, you see that the disc herniation is well off to the side. It is not touching the spinal cord, so you can reach the disc fragment from behind, just like in the lower back operation. By reaching the disc fragment from behind, you can pluck out the disc fragment and not need to fuse the spine. The location of where the disc fragment is, if it's off to the side and you can reach it from behind, a posterior keyhole laminotomy discectomy operation is commonly done. If the disc herniation hits the spinal cord, you cannot move the spinal cord over to get the disc herniation from behind, so you must approach it from the front. And an anterior discectomy and fusion, or an anterior discectomy and disc replacement, are the three treatment options. Going in from the back and removing the fragment, but do not fuse. Going in from the front and removing the fragment and fuse the neck. Going in from the front, remove the fragment, and put in a disc replacement are the three options. So the next topic is artificial disc replacement of the lumbar spine. Now we remember from our discussion of the neck or the cervical spine, disc replacement in the neck was done for disc herniation. It is not done for disc herniation in the lumbar spine. The simple operation of removal of the disc fragment is all that's necessary, so disc herniation is not a reason for doing disc replacement in the lumbar spine. In the lumbar spine, if the disc internally starts to fail, that means it's starting to collapse, it's becoming painful. It has not herniated, but it has worn out. That becomes the major reason for replacing the disc. And again, we're looking at a model taken from the lumbar spine. Any single level is represented by the model. And what the model shows is when the disc is completely removed, a base plate and articulating ball are placed in the bottom, and a plate with a perfectly radiused cup is placed in the top. A sintered surface that allows the bone above to bond to the disc replacement and the bone below to bond to the disc replacement is used to replace the disc so that movement of the spine continues to flex and extend, to lateral bend, and to rotate as the spine normally does. This operation is done to preserve motion. It's done through an incision in the front of the spine, so going through the belly, or it can also be done through an incision on the side of the spine, going through the side of the abdomen, and is much less frequently done than the cervical disc replacement that we have already talked about. The difference for lumbar disc replacement is the disc is replaced when it has internally failed to work and become painful. It is not replaced for a disc herniation problem.